Sir, we are live now. With all your permission, I am starting this webinar
Yeah, sure.
for today with your permission, sir.
Yeah.
Very good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Ratan Jha, sir. And let me share some of the achievement of sir. Sir is a senior nephrologist and transplant physician at Care Hospital, Banjara Hills, Hyderabad. And today, sir is going to discuss on a topic timing and initiation of dialysis in CKD patients. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. The stage is yours. You can proceed from here, sir.
Thank you. Good evening, everyone. Today, I will be briefly talking about the timing and as well as initiation of dialysis in chronic kidney disease patient in a simple way, which will be useful for those who are practicing not as a nephrologist, but as a non-nephrologist taking care of patients in the remote areas. So when we talk about dialysis, the following points comes to our attention. So what is the real indication of initiation of dialysis? When we try to withdraw the dialysis or stop dialysis, what are the types of dialysis that we talk about? What are the frequency of dialysis? Whether hemodialysis means blood transfusion, but that is not the case in most of the situation. And what are the anticoagulant that we use patient, whether it is heparin, heparin-free, or some other kind of anticoagulants like citrate, which are commonly used in a critical care setting. So when we talk about hemodialysis in chronic kidney disease, it can occur in two situations. One is a patient who has slowly gone into stage 5 chronic kidney disease over time, which is called progressive chronic kidney disease. And when the person requires dialysis in the stage where the GFR is below 15, it is called end-stage renal disease. The term ESRD has been discontinued because it gives a feeling as if the life is ending. Hence, the term stage 5D we talk about. Stage 5 means GFR below 15, D means dialysis dependent. So this is one kind of patient where hemodialysis is done on a long-term basis. But there could be another situation where the patient has a chronic kidney disease and suddenly becomes unwell because of acute kidney injury getting superimposed, which is either in the critical care setting or in the community-acquired setting because of infection, drugs, or pregnancy, etc. Or because of the factors which we try to remember in this context as fiasco factor that we'll talk in the subsequent slides. So it could be an AKI on CKD when a dialysis may be required, or CKD slowly going over time to stage 5D CKD where dialysis is required. One has to understand that though the problem of CKD is increasing in the world, 10% or more of population throughout the world is having chronic kidney disease, but out of this population, only 3% of patients reach a stage of dialysis, which is called end-stage renal disease. So it is not as common as the disease prevalence is there. Hence, one has to understand that all the patients of CKD may not reach a stage of dialysis. So when we talk about dialysis, the first question comes to anybody's mind is that how long the person will live on dialysis, or what is the mortality rate in dialysis. What is shown in this slide is that patients who are on chronic hemodialysis has an average longevity of 5 to 10 years, depending on many factors. And if you compare this with other form of therapy that is offered to such patient, a renal transplant, the longevity is to the tune of 15 to 20 years, depending on the various factors. So dialysis also gives a good kind of longevity, but the best longevity is seen in patients who does well on transplant or renal transplant. But in contrast to the longevity of around 5 to 10 years on dialysis, chronic hemodialysis, the mortality in patients who require dialysis because of acute kidney injury in the setting of no previous kidney disease or the setting of background CKD in a critical care setting is to the tune of 40 to 55% in different reports. That is, 1 out of 2 patients die in case they require dialysis and require hospital admission in ICU. And this mortality is higher than what is reported for heart attack, sepsis without kidney injury, and a patient who has respiratory failure alone requiring ventilation. So an AKI on the backdrop of CKD or without any backdrop CKD has a higher mortality. And this is in contrast to the better kind of longevity on patients who are on hemodialysis. This is an old slide from the US RDS registry, that is US data registry, that what is the life expectancy in a patient in the younger age group versus the older age group, depending on the frequency of dialysis. What is shown in the upper half of the slide, that patients in the age group of 45 to 65 is the commonest age group on dialysis throughout the world. The person who receives a conventional 3 times per week dialysis, the longevity is 5 years compared to about 10 years in people who are younger with the same 3 times frequency of hemodialysis. But if the dialysis is made on a daily basis, that is 6 days a week or 7 days a week dialysis, the longevity doubles from 5 years to 10 years in the older age group, and from 10 years close to 20 years in those who are younger age group. So this longevity depends also on the age as well as the frequency of dialysis. It is reported the average life expectancy throughout the world is about 5 to 10 years, but many patients will live on dialysis more than 20 to even 30 years. So it's not that the people cannot live beyond 10 years. It all depends on many other associated comorbidities. So when we talk about dialysis, we talk about the GFR, the CKD stage 5. We need to have a kind of clear-cut calculation of the GFR based on the right equation, which is available on the app from the National Kidney Foundation, which can be downloaded on the smartphone. We can use the CKD EPI creatinine equation 2021, which is the thing which is advocated, and based on the age, the sex, and the serum creatinine, which is fed into the computer in that app, so automatically we get a GFR for the right patient. And based on the GFR, we try to say that patient is stage 5 or not. Stage 5 means a GFR below 15 ml per minute per 1.73 meters square. There are other formulas, the revised bedside Schwartz formula, which is applicable for the age group of 1 to 17. Cochrane-Ward formula is no longer used. CKD EPI creatinine cystatin based equation is utilized in situations where the creatinine values could be misleading, like person who is malnourished, a person of hepatorenal syndrome where the patient has cachexia. There, these two values could be included to decide the right kind of GFR. So this is a GFR which is called eGFR or estimated GFR, but there are other ways to measure the GFR, which is called measured GFR, which could be slightly different from what we calculate by this formula. But this formula is usually enough for most of the situations where the patient's creatinine is stable, and that is the thing which is advocated by National Kidney Foundation to decide is this patient coming into stage 5 CKD or not. As a nephrologist, we expect the general physician to know that there is another kind of formula which is called kidney failure risk calculator, which is proposed by KDIGO to decide the referral to the nephrology team or a team for transplantation. This kidney failure risk calculator depends on 4 parameters: the age, sex, then GFR based on serum creatinine, and the urine albumin creatinine ratio with a region specified. So once we put these parameters in this calculator, automatically it gives a kind of risk of going to dialysis need at 2 and 5 years. And based on the projected risk of kidney failure, the patient is supposed to be referred to the nephrologist. So this is simple calculator which is available on the net to be downloaded and utilized. And it is said that this risk calculator gives an idea based on the 4 variables that we talked about, but there are few more variables which can be utilized for getting the right kind of risk. They said that at 2 years, if the kidney failure risk is more than 10% based on this calculator, this patient is the right patient to refer to a nephrologist or a team where nephrologists and other urologists and dietitian, etc. are there. And if the risk is more than 3 to 5 years at 5 years of kidney failure requiring dialysis, the patient has to be referred to a nephrologist. So that is the concept of referral in the Western countries to make the thing streamlined. Because we know that though the 10% CKD population all over the world is suffering from kidney disease, only 3% patient requires renal failure, require dialysis for renal failure throughout the world. And hence, large number of patients can be treated by primary care physician. It has been reported that above the age of 65 years, 25% of people are having a chronic kidney disease based on the low GFR below 60 or albuminuria. So these are the guidelines to decide when to refer to a nephrologist and what will the nephrologist do after a proper evaluation, when will he use dialysis. That will be discussed in subsequent slides. So the need for dialysis in the context of chronic kidney disease is the situation where the person is having an end-stage renal disease. That is a stage of disease where person's life cannot be managed without a dialysis support for a long time. This stage is defined as GFR when it is below 15 ml per minute persistently, and this ESRD could arise from a disease which is slowly progressing, that is progressive CKD, or it could be because of the rapidly progressive renal failure where the person develops kidney failure requiring dialysis over 3 months' time when the kidney size may be even normal. And occasionally it can be seen when a patient has developed a serious acute kidney injury which required dialysis, but it never got resolved and it continued beyond 3 months to be classified as CKD. So it could be a slowly progressive CKD, rapidly progressive renal disease, or the acute kidney injury not resolved, going straightway into end-stage renal disease, which we see commonly in an anuric stage postpartum with the acute cortical necrosis because of various reasons, because of snake bite, because of acute pancreatitis of serious nature, and sometimes because of immunological disease even post-transplant. So the end-stage renal disease is commonly because of the chronic disease, but it could start with a acute disease which are not resolved or rapidly progressive disease, and the situation is same where dialysis has to be given on a long-term basis. That stage 5 kidney disease, which covers end-stage renal disease, are classified into two stages or two categories: stage 5D or stage 5 ND. D means dialysis dependence and ND means non-dialysis dependent. So the treatment options in a patient who has GFR below 15, which can be considered as a ESRD if they are on dialysis, are listed in the slide. That all the patients who goes for dialysis are not only getting a technical treatment of dialysis, that is hemodialysis or peritoneal dialysis, but also getting a medical treatment, replacement therapy for associated renal anemia, metabolic acidosis, fluid overload with edema, electrolyte disturbance in the form of hyponatremia, hyperkalemia, dyslipidemia, anorexia, and nutrition. So medical replacement therapy is a part of which is to be provided along with the renal replacement therapy, which is usually hemodialysis in our country. 90% of patients are on hemodialysis, and 5 to 10% of patients in different centers are on peritoneal dialysis, which is also a form of dialysis. The person is not getting blood circulated in the system to be cleared. Renal transplant is also an option, which is called a renal replacement therapy, and this is usually given after a person started on dialysis, but it could be offered preemptive, that is even without dialysis when the GFR is below 15 and patient straightway is worked up for transplantation. There are many patients who either do not want dialysis or they are not fit for dialysis, where we give a palliative care, which could include even the enteral dialysis, where the gut is utilized to take care of uremia, which is called enteral dialysis. So the commonest form of dialysis throughout the world is hemodialysis, and hemodialysis are various types. One is low flux dialysis or the conventional hemodialysis, where the filters which are used are less permeable. There's a dialysis where the filters are more permeable, which are called high flux dialysis, and this type of filters are used for a different kind of unconventional dialysis, which is hemodiafiltration, which is the commonest form of dialysis in the Europe, in contrast to US, where the conventional the low flux dialysis is done because of the cost cutting reasons. There are newer types of membranes which have come, which like Terranova kind of type of filters, which has the benefit of the hemodiafiltration, and at the same time having a higher flux for using it during the dialysis with a conventional machine. So there are different types of dialysis which can be offered, and the best form of dialysis at this point of time is hemodiafiltration, followed by membrane related uh, hemodialysis, and then maybe conventional hemodialysis. The duration of dialysis, the time of dialysis, the location of dialysis, and frequency will characterize the type of dialysis the person is receiving, which we saw in the subsequent slides. But before we go to dialysis, what is the minimum thing required to run a successful dialysis program? Most of the patients will require an anticoagulation, and one has to have clear idea about the patient bleeding risk before dialysis is chosen. Hemodialysis does not need blood transfusion, but blood can be given during bleeding states with very low hemoglobin or symptomatic angina. So the blood dialysis doesn't mean the blood has to be given, it is only required in a select situation. For a good quality dialysis, you need to have good quality water, and for that you need to have a good system which uses the RO or reverse osmosis membrane to deliver the good quality water. And based on this good quality water, we may do a conventional hemodialysis, or we may do a hemodiafiltration, or a CRT can be utilized, where the dialysis can be offered with a similar kind of support. What we require is a trained medical or paramedical team to look after the patient during dialysis, because it is a dialysis which is so fast, and if the needle gets discontinued, the patient can have a loss of blood within no time and die. So this requires a system where things are monitored, patients are getting the right kind of dialysis prescription, and are followed up to decide appropriately what is to be done. So the dialysis which is given can be given at night time, when it's called nocturnal dialysis, or daytime, which is the commonest time when dialysis is done. It could be done at home, then it is called home hemodialysis, or it can be done in center in the hospital, it's called hospital hemodialysis. It could be done 3 times a week, which is conventional frequency dialysis, or every day, that is quotidian dialysis, or a duration of dialysis could be short dialysis, 2 hours short dialysis, daily dialysis, or 4 hours dialysis, or 8 hours dialysis, which is usually done at night. So short dialysis is usually a dialysis which is SD, which is done short daily hemodialysis 6 days a week, while the conventional dialysis duration is 4 hours, 3 times a week. And if the duration has to be prolonged, it is usually given in the night time or nocturnal hemodialysis. So there are different names which are associated with hemodialysis, and one has to understand which form of dialysis is good for the patient and what can be offered at the center. The indication of any form of dialysis is either based on clinical symptoms and signs, or based on the biochemical report, which suggests to support the clinical sign as uremia, or it could be an absolute indication for dialysis, which could be life-saving, like a patient having severe pulmonary edema, or a patient who has severe hyperkalemia not responding to medical treatment. So the usual clinical signs and symptoms of in a patient of stage 5 CKD is shown in the slide as clinical signs. Patient can have a uremic encephalopathy, which can evolve into coma. The term encephalopathy means the person is not mentally alert, and coma means he is totally unconscious, unresponsive. Patient can have seizure or convulsion, which could be because of uremia, though there are many other causes of convulsion which can be seen, which has to be excluded. Patient can have a GI bleed in the form of hematemesis or melena, which could be a part of uremia. Protracted vomiting is the commonest symptom in many patients of chronic kidney disease with anorexia. Pericarditis or chest pain could be a symptom in a patient who has advanced renal failure. Pulmonary edema with cough and PND could be a symptom. And acidotic dyspnea, a peculiar kind of hissing sound while patient is breathing, is also a clinical kind of symptom, a sign for deciding about dialysis. So these are the overt symptoms of uremia, and this is usually seen when the GFR is between 5 to 8 ml per minute, based on the formula that we discussed. And these clinical signs are usually supported by lab investigation. Urea more than 200, creatinine around 8 milligram, serum bicarbonate below 15, which produces acidotic dyspnea. Potassium could be high, more than 6. Sodium could be low because of fluid overload, less than 120. Calcium above 15, uric acid could be above 15. So these lab reports, in conjunction with the clinical signs, with the calculated GFR, will be a way to decide whether the person needs dialysis or not. Most of the time, they go hand in hand. And in case there's a discrepancy, the clinical judgment is important, is required to decide the patient is going to get benefited with dialysis. Dialysis options are hemodialysis, peritoneal dialysis, and chronic arteriovenous hemodialysis, which is called a CRT therapy, which may be offered in a situation of hemodialysis where the person is hemodynamically unstable. Earlier, the concept was that you should be aggressive to start dialysis early when the GFR is below 50. But this concept was challenged by many reports, and one of these reports is shown that early dialysis initiation when the eGFR based on the formula was 8 and measured GFR based on the measuring was 6.6 were not associated with any improvement in survival. Based on the kidney function, this study suggested that some patients could be started when the eGFR is below 6 and mGFR is below 4 if the symptoms permit it. And based on similar reports, the KDIGO, the Kidney Disease Improving Global Outcome guideline, has suggested that current clinical guideline recommend to initiate dialysis in the presence of symptoms or signs that we discussed attributable to kidney failure. This often occurs when the GFR has fallen between 5 to 10 ml per minute, 1 per 1.73 meters square. So one has to be sure that symptom what we are referring to is because of kidney disease before or dialysis is initiated. In patients who are asymptomatic with low GFR, one can follow it up. There is no need to start dialysis early. This is one of the patients EC that we see. That patient has come at 5 o'clock early morning, way back in 2004. Patient was a patient of chronic kidney disease, and suddenly patient has become breathless and come early morning. And what we see in the ECG is a tall peak T wave with no absence of P wave, suggesting that it is severe hyperkalemia. This patient was having a potassium of more than 8. Patient was given a medical treatment and was initiated immediately on hemodialysis because patient had missed her dialysis and had taken a lot of fruit juices prior to coming to the hospital. So this is an absolute indication of starting dialysis in a patient who is having chronic kidney disease and who has missed her dialysis and is having this kind of ECG abnormality because there's not much time, and this can lead to a kind of cardiac arrest if the things goes beyond a limit. The dialysis usually in a chronic kidney failure setting is a kind of painless procedure. What we see on the left side is a young patient who was having a chronic kidney disease because of IgA nephropathy and was getting an outpatient dialysis through her hand, where an AV fistula was made to go for long-term dialysis. This patient ultimately had undergone a cadaveric transplant and doing well. The other side of the picture is an elderly lady of about 70 getting hemodialysis through the fistula and feeling comfortable. So hemodialysis is an outpatient usually done in a planned way where the fistula in the hand is made, which is a kind of communication between arteries and veins to make the veins prominent and get a good flow. So in absence of making a kind of vascular access in the hand, people require dialysis through a catheter which is put in the neck as a kind of intrajugular vein. But that is not the best option, but that could be done in an emergency situation when the patient has not planned for a long-term dialysis. So one has to remember as a kind of treating physician that dialysis is not only a technical procedure of giving 3 times a week dialysis in hospital or in home, but there are many other things which have to be done together to give a good quality life and have a longevity of around 5 to 10 years in most of the patients. It is said that preventive care in the form of immunization should be considered. We should, in patients who are elderly, we should look after the hearing and vision because many of them they are having a kind of mild deafness or having cataract, dental problems to take care of with the appropriate referral because that will lead to kind of anorexia. The problem of fall and frailty is there because most of the elderly will lose their muscle mass over time and can have the risk of falling, and that has to be also prevented by appropriate counseling. Healthcare counseling team, if available, should also suggest them the appropriate exercise, ways to lose weight in case they're obese, to avoid alcohol and tobacco. And persons who are younger, etc., who are not going for transplant, contraception and sexual dysfunction has to be also looked at. Screening for cancer, because patients who are on long-term dialysis, elderly patients are also high risk of cancer. And there are certain cancers like renal cell carcinoma or bladder carcinoma could be a problem that has to be screened appropriately every year. Cognitive impairment is a problem in elderly, has to be appropriately addressed. And depression is always lurking not only in the patient but of the caregivers, which has to be addressed to get the treatment appropriately. Advanced care planning is also very important because patients who are not improving, one has to talk about the what is to be done in case person has an arrest on dialysis, what are the life-sustaining treatment to be given when person has this kind of problem, has to be discussed with the patient. That is the terminal care management in patients who are doing bad on dialysis. So the specialty of nephrology has evolved over time, and people who are on long-term dialysis may also have to undergo a kind of care which could be considered a palliative care, where we give a symptomatic management. We 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 involve the patient's attendants in decision making. We involve the other interdisciplinary team for social, spiritual, and nutritional distress. And we try to even remove the kind of guilt in many patients who are not able to get the full treatment by providing an appropriate conservative care and suggesting how to go opt for the end of life care, advanced care planning as appropriate. So when we talk about principles of palliative care in our day-to-day practice, this is a modernized Hippocratic oath which is listed that I will apply for the benefit of sick all the measures that are required, avoiding those twin traps of overtreatment and therapeutic nihilism. Either that means that either I will not go for over excessive therapy, which is costly and may not be a kind of pleasurable even for many patients, and therapeutic nihilism, that is, we will not do anything. Once they have decided that they don't want dialysis, we will not give any kind of supportive care. So that is the concept, that we need to give a care so that the patient as well as their caregiver are not feeling a kind of uh, feeling the caregiver are not feeling that they have left the patient in between, etc. The guilt has to be removed because many patients cannot afford the therapy and their attendants keeps on having a guilt that they could not take care of their kith and kin because of financial matter. So one has to talk to them, give them some therapy so that they feel comfortable that whatever they could do was done with dignity for the patient. The domains of supportive care is listed in the slide because these things are being talked in the recent time quite often because more and more patients are living long enough to require dialysis, which is a costly therapy. That is symptomatic management, expert communication, interdisciplinary team approach where you should have a nurse, dietitian, palliative care specialist, social worker, and even the spiritual workers. Option of comprehensive conjunctive care can be discussed with which can maximize the quality and quantity of life, and end of life care where an optimal use of hospice, maximize dignity and bereavement support should also be available where it is appropriate. There is a concept of using gut as a dialysis where symbiotics have come into picture, and that can be offered to people who do not want hemodialysis to be done at any cost. So that was all about the indication, the ways to manage a patient of chronic kidney disease on dialysis. But there is another group of patients who have an acute deterioration of kidney function in the backdrop of chronic kidney disease, where the indications could be different. We know that when acute kidney happens in the background of chronic kidney disease, it is commonly because of acute factors, which are listed as fiasco factor. F for fluid underload or dehydration or fluid deficiency, I for infection, A for problems associated with arterial blood pressure, that is low blood pressure or high blood pressure. As for substance abuse, like taking a kind of analgesics or aminoglycoside, C for consumption of very high protein or some fancy diet, and O for obstruction should not be there because these are the factors which can lead to sudden change in kidney function. And when we see a patient of AKI, the commonest reason we find in our day-to-day practice is as a fluid underload or dehydration, I is for infection, though other factors like obstruction could also be a part. So this has to be looked at, And this could be the reason for getting this kidney failure in the community. And patient may go to the hospital or may go to the critical care zone depending on the general condition. The commonest reason for dialyzing a patient of AKI in the background of CKD is for acidosis, hyperkalemia, and azotemia, that is urea more than 200 that we talked about, and creatinine lower, above 4 could be one of the indications. And fluid management are the common indications for AKI. That is, fluid management means if person has pulmonary edema, then we may have to dialyze the patient. Earlier, I believe that early initiation of dialysis in a patient with AKI on CKD or without CKD improves survival. But the evidence is in favor of earlier dialysis or aggressive dialysis is lacking. And we these days we say that we need to choose the right time to start dialysis. The conventional indication, therefore, of dialysis in the acute care situation with the background CKD is fluid overload, acidosis, and hyperkalemia. But in a situation of ICU, the other indication of dialysis could be to manage the other organs, like in patient for multi-organ support, where the person has cardiac dysfunction or respiratory failure, or a person has a kind of hepatic failure, where this can be done even if the classical indications are not there to support the organ function. So based on the factors of severity of AKI, the risk associated with kidney replacement therapy, the severity of critical illness, and other factors like availability of machine, one may decide to initiate dialysis in an acute or a chronic situation in the intensive care. And this slide highlights the point that how to go about it, that if we find there is an urgent complication of AKI that in the background of CKD, which can be modified, then we should go for dialysis like hyperkalemia, pulmonary edema, or seizure because of the uremia. But if it's not, then we try to support the patient with fluid balance and other kind of things like infection management. And based on furosemide stress test that give a laxation after BP is maintained to see is he passing urine or not. And if that is not happening, the person is definitely going to get the urgent indication of AKI subsequently over time, which has to be dialyzed. If the person is not recovering in 72 hours time, the creatinine is going to increase and the person will develop a biochemical indication for dialysis and the patient has to be offered at that point of time. So the types of renal replacement therapy in an AKI with the background of CKD is shown in the slide, that the conventional dialysis like hemodialysis or slow low efficiency dialysis, the usual thing that we do. But chronic renal replacement therapy, CRT machine can be used, which is a 24 hours dialysis that can be offered in people who are hemodynamically unstable. Peritoneal dialysis is also one form of dialysis which can be offered in a patient who is having bleeding tendency or where the machines are not available. Added devices like ECMO, MARS, cytokine adsorption, charcoal hemoperfusion could be utilized as appropriate in a situation of AKI with other kind of associated problems in the background of CKD. So this is just a picture to show you the heart looks normal inside. This is a patient who developed sepsis with acute kidney injury in a post-nasal transplant situation. And what we see, that person was anuric and was given enough fluid to raise the blood pressure and develop pulmonary edema. So his creatinine was not raised, but he required an urgent dialysis to take care of the fluid. So this is an absolute indication for dialysis in an appropriate situation. So this is just a slide to tell you that what is the report about the early versus late initiation of kidney replacement therapy in a situation where the person has an acute kidney injury with or without background kidney disease. So there are many trials, ELAINE, AKIKI, IDEAL, START, AKIKI 2. But what was ultimately concluded based on this trial is that overall the study provides reasonable assurance that it is safe to postpone the kidney replacement therapy in patients till the stage 3 AKI develops, where the prolonged oligonuria and person blood urine nitrogen below 112 without any urgent indication. So early dialysis was being proposed, but now it is said that we can wait till stage 3 if the person has a blood urine nitrogen less than 112, and there are no urgent indications like hyperkalemia, metabolic acidosis, or pulmonary edema. Early dialysis means dialysis within 24 hours, but the late dialysis means dialysis after 72 hours of insult. So in this context, when we talk about dialysis, this formula I found it quite useful. The SCAM criteria of initiating dialysis, the AEIOU-O2 formula, which helped us to decide when to dialyze in acute care setting, where the classical indications are not there. That is, A stands for acidosis, where the pH below 7.2. E stands for electrolyte disturbance, which is more than 6.5 potassium despite on treatment. I for intoxication, O for anasarca with hypoxia, U for uremia. And when the urine output is less than 100 ml or 5 requirement more than 70%, then the patient may require dialysis. So this is SCAM criteria, which was devised by Brigham and Women's Hospital. And what was suggested in an actual clinical setting, if the more than 2 criteria gets fulfilled, probably patient may require dialysis, and if more than 3 criteria are there, then definitely patient is going to need dialysis, and dialysis has to be started. So that the form of dialysis that we do in acute care setting is shown that in adult patients in COVID times with multi-organ support, the kidney CRT machine, patient is getting the respiratory support, and patient is having a kind of invasive monitoring for the water support by PICO machine. The other form of dialysis that is done in children is a kind of peritoneal dialysis, and here the catheter is put and person is having a kind of continuous dialysis. The C word stands for chronic, but this is done even in the acute care setting with ambulatory peritoneal dialysis. The concept is same, that PD can be offered in a situation of acute dialysis in a background of CKD when need arises. So whenever we talk about decision making, it is very important that we understand the clinical picture, assess the renal prognosis as well as overall prognosis of the patient. We should arrange the meeting of the patient, family members, and other key members of the care team to decide what the best option and align patient goal and value of the treatment plan. That is, there is nothing called a fixed rule that every patient will have to have a need for dialysis. This has to be done in consultation with all the people who are involved in the care. So that was all that I wish to share with you about the indication of dialysis and the long-term planning that has to be done in a patient of CKD or AKI and CKD. Thank you. If there are any questions, I'm willing to take.
Thank you so much, sir, for giving your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants during the practice. Sir, we have received some questions, sir. If you allow, with all your permission, shall we take this question?
Yeah, quickly.
Yeah, the first question is from Dr. Agarwal. He is asking, have you encountered any particular challenges of dilemmas in deciding the timing of dialysis for your patients, sir? What's your point of view on that?
The the common kind of block that we have seen in when we want to start a dialysis first time is that patient feel that dialysis is a painful option. Once you start a dialysis, it is a lifelong dialysis. And the multi issues which are involved is also a block that we have seen, etc. So we tell the patient when we start dialysis is a support and not a cure. If it is a chronic renal failure, dialysis is going to improve the patient condition, but not the kidney failure. And they have to accept that. The cost matters are always a point to be discussed. And if the things are planned out, the cost is less because patient gets dialysis and outpatient from the fistula. If the costs are, if the patient do not plan it out, then they require hospitalization, catheter placement, pain is there, and cost is there. So everything has to be discussed and told clearly so that they can take a clear-cut decision.
Thank you so much, sir, for sharing your insight on this question. We have another question from Dr. Subramanian. He is asking, what clinical markers are the most critical in deciding when to initiate dialysis in CKD patients?
This is very clearly spoken in the KDCO trial that no biochemical formula is appropriate to say that dialysis is required. You have to have a biochemical support, a clinical kind of judgment that the symptom that the patient is referring to is because of uremia. Because convulsion, for example, could be because of high blood pressure. Convulsion could be because of any other kind of diseases which can mimic like a uremic convulsion. So one has to be sure that this convulsion is because of kidney disease or not because of any other disease. So symptom has to match with the biochemical report. It has been seen that when you have the commonest symptom that we see in a patient with kidney disease is a GI symptom of anorexia, vomiting, hiccups. These are the common symptoms of GI and the cardiac symptom in the form of breathlessness and sometimes itching that is there. So these are the symptoms if it is present along with a raised urea, which is usually more than 200 for chronic patient. This supports the diagnosis that this symptom could be because of kidney failure. And if you do an ABG or a blood gas analysis or a serum bicarbonate, you'll find that bicarbonate levels are very low. symptomatic bicarbonate levels are usually below 15 this millicon per liter. So all the things have to be taken together. Not even a single kind of lab report is sufficient to make kind of a decision that the patient requires dialysis. If patient has a very severe hyperkalemia, then one may need to go for dialysis like the patient has showed, but that can be managed with giving diuretics if the person is passing good amount of urine and along with the calcium, the IV calcium. So medical treatment is always an option in an appropriate situation, but when it fails, this dialysis has to be done as a life-saving option. And dialysis is never a cure. Dialysis is only support for life.
Thank you so much once again, sir, for sharing your expertise on this question. Moving forward, one last question from Dr. Agniotri. She's asking, like, what are the key components of pre-dialysis care that can impact the timing of the dialysis initiation?
Yes, this is a very important question. It has been reported in the literature that patient who goes to dialysis within the 3 to 6 months of nephrological care, they do not do as well as those who go to dialysis after 6 months to 1 year of nephrological care. Because the patient who come for who are getting late referred, they are not usually having a kind of vascular access or AV fistula. Their anemia is not well managed. They are not mentally tuned that dialysis will be a long-term option. They are nutritionally depleted, they are malnourished. So these things can only be treated on a long-term basis. If the person comes to a nephrologist with at least 1 year of pre-dialysis care available. So it is said that patients should be referred early, and that's why we discussed that KDIGO calculator of 2 and 5 years of kidney failure for people to refer to a nephrologist. It is very clear that a person who has a GFR below 30, if the chronic disease, should be referred to a nephrologist in a simple statement for a good kind of management of blood pressure, anemia, vascular access, vaccination, diet, and priming the patient that the treatment of dialysis and transplant can be offered based on his willingness to go for the right kind of choice that he wants to make. In case he doesn't want to go for dialysis, the palliative care can also be offered, particularly in elderly patients, in consultation with the family members.
Thank you so much, sir, for sharing your insight. I hope that all the answer which you have given will be impactful for all the doctors out there who is on this session, sir, and all the PG students, sir. And thank you so much once again for taking out your valuable time, sir. As there is no more question, with all your permission, shall we conclude this session for today?
Yes, yes. Thank you.
Okay. Welcome, sir, and take care of yourself, sir. Hope to see you again in future also with different
Sure.
topics, sir.